everyone. For those of you that don't know me, my name is Rachel Himes. I am a student at Ohio State University, and for the past few months, I have been doing my capstone experience under the mentorship of Marla. So today, I wanted to kind of, as I wrap up the last few weeks of my capstone experience, talk to you one last time about evidence-based practice. I know that I've been harping on this for the last couple months, and I really appreciate everybody's participation and enthusiasm behind this because we all know how important it is. So this is my last lecture that I want to leave you with and just kind of wrap everything up. So let's begin. So evidence-based practice, or EBP, just as a quick review, is more than just evidence. I think a lot of times we think of evidence-based practice as taking science and putting it into practice, and that's really not getting the full picture. As you can see, I think it's important to include that your clinical expertise and client-centered care are the two other pieces that need to be included in evidence-based practice, because your clinical reasoning is evidence-based. All of your experiences in watching patients grow and change and evolve and go from a lower level to a higher level, that is evidence. And I think a lot of times we forget about the power of anecdotal evidence. So combining the three elements of best research evidence, as in articles, your clinical expertise and experiences that you've had as a clinician, as well as the patient values or client-centered care, all three of those values must come together, and that is evidence-based practice. So who cares about evidence-based practice? You should. Really, your buy-in is so important in evidence-based practice, because if you don't believe in it, why would you do it? You got into this profession to help people, and the most effective way to help people is to implement evidence. So let's talk more about that. Only 69% of OTs base their clinical decision-making on research evidence 25 to 50% of the time. This statistic was found in, I believe it was a Swedish study that was looking at OTs and how often they use evidence-based decision-making. And just to break down that quote a little bit, because sometimes numbers just like cloud our understanding of things. Essentially, what they're saying is the majority of OTs are using clinical judgment, but they're only using evidence-based decision-making 25 to 50% of the time. So you've got less than all OTs are using that evidence research, like less than half the time. And I think it's kind of strange to conceptualize in that way, but we really want everybody to be making those decisions at least 50% of the time. And obviously, in a perfect world, we would all be using it all the time. That's not realistic. But it is concerning that not everybody is incorporating research into their clinical judgment, at least partially, at least part of the time. So it's really up to us to change these numbers and to advocate and talk amongst ourselves and become champions of evidence and help each other understand why it's important. So let's talk more about importance of evidence-based practice. The first thing I want to talk about is it's your license on the line. You got into this profession knowing that you were treating patients. You are altering the course of their life by treating them in the rehab setting. And it's your decision how you want to treat. But what it comes down to is what level of quality of care do you want to give as a professional? Evidence equals power. So by justifying the treatments that you feel are powerful, you can justify why insurance should be paying you for the things that you know are important for that patient. Evidence typically leads to better outcomes, which leads to happy, healthy patients. What could be better than that? That's exactly what we want. And then we get those happy, healthy patients. Where you work has a higher patient turnover rates and you bring in more revenue, which a lot of times we don't care about as clinicians, but if you think about it in the idea of if you have more revenue, that that site can then give you more resources. If your site is not making a high level of revenue and you say, oh, like, I really want to get this really cool new virtual reality set and I know it's going to be better for our stroke patients. If you have a site that's just barely getting by, that's no way they're going to even listen to your proposal. But let's say you bring forth a bunch of evidence and you say, look at all these resources that say virtual reality has become extremely evident and crucial to the recovery of a stroke patient. You justify it, you find funding, you write grants, whatever. You have a pretty good shot at getting the resource that you want. So that's how I like to tie back revenue into our care as clinicians, because a lot of times it's like that sort of thing is out of our minds, but it does come back to help us in the end. So I think, as I mentioned before, we talked about the 3 realms of EBP, but a lot of people say, what about the value of experience? It's great that we have evidence out there in articles, but what about my experience as a clinician? And again, this is just one piece of evidence-based practice that we need to be incorporating. It should not be underestimated that your experiences are valid and crucial to your treatments as a clinician. And that doesn't go unnoticed. Those of you that have been treating for 10, 20 years, people do seek your input when we're seeing clients where we're thinking, I'm not sure if I know what to do with this person. And I think sometimes that's what's really nice about working in a setting with more experienced clinicians, because you've seen thousands and thousands of patients and you've had those moments where you've had those really tough clients and you have a breakthrough and you think, oh my gosh, I can't believe this worked. I can now use this in the future and help other clinicians in treating difficult patients. So in summary, relying solely on clinical experience is really not good enough. And we do need to be incorporating new evidence and things that we're finding. But it's those things together that make the best clinicians. The most dangerous phrase in the language is, we have always done it this way. And I wanted to throw this quote in there because I think sometimes we can get stuck in our ways as clinicians and we find things that we're like, oh, I know this always works and I'm going to keep doing it. That's great to have that in your arsenal, but we have to keep learning. That's why we're required to do continuing education. There are always going to be new, inventive, innovative things that are emerging. And it's such a cool opportunity for us to say, okay, let me try this. And I think it's also important to remember that you can always try something. And if you're either not comfortable implementing it or you feel like, I'm not sure if this is really working, then change it. I think it's just the curiosity and the openness to new things that's really important for us. So also there is the kind of counter argument of, I've used this intervention on countless patients, it's always effective. And I wanted to bring up the metaphor of, so you can rub 2 sticks together and you know that that's an effective strategy to create fire. We know that it works. But there are ways that can be more efficient and allow us to achieve the same exact results faster and with higher levels of efficacy. It's not wrong to rub 2 sticks together and make fire, but like, maybe we should see what happens when we try a match or a lighter. My point being, there may be new emerging practices that we now find are more effective at creating that same awesome patient outcome rather than these more traditional techniques. So again, I think I would urge you to stay curious about emerging practice. So I want to call upon you to just sort of reflect on your own practice and think about, maybe your last 5 treatment sessions and think about, was it functional? Probably, because we're occupational therapists. Was it occupation-based? A really important question. Meaning, were you doing a treatment of an actual toilet transfer if that person was struggling with toilet transfers? Or were you doing sit-to-stands? If that person was struggling with grabbing their coffee mug in the morning, were you having them reach out and grab a coffee mug to bring that to their mouth? Or were you doing them reaching out for a cone? Occupation-based. Were cones, beanbags, pegs, or other functionless items involved? This is more traditionally, these items are used in skilled nursing facilities. We do see that, but they are not functional or occupation-based items. So just reflect, When was the last time you used those items? Was heat ice applied without an occupation-based intervention simultaneously occurring? So that would be apply the heat pack and walk away. Was a stroke patient asked to use overhead pulleys? Or this last one, not as relevant for us at Menorah Park, but was a sensory intervention used with a child that had not been assessed for sensory deficits? The reason I ask these questions in particular is because of the Choosing Wisely campaign that AOTA issued, I believe in 2018. And this was really what drove my capstone. It has evolved very much over the past 2 years, but this really inspired me because this initiative was recognizing that there are practices out there that need to be de-implemented. There are practices being completed that could either be harmful or simply they are not effective or functional. And essentially, it's a call to provoke thoughtfulness among our OTs and just reflect on what interventions are we doing, why are we doing them, and is there a better way to be doing these things? And I just encourage you to explore AOTA's website. It's a wonderful resource if you don't already utilize it. There's a lot out there, alternatives to using certain just non-beneficial, non-functional, non-occupation-based treatments, because we know that there's a lot of evidence that occupation-based treatments and functional treatments are actually better in connecting the neural pathways that need to be reconnected for rehabilitation. Another counter argument I get when I talk about like not using the arm bike is, but the arm bike is such a good warm-up exercise. I've been using cones and pegs since I started practicing. This is the #1 Choosing Wisely campaign de-implementation strategy. This is something that we should not be using. I think it's time to ditch it, plain and simple. There is no science to support non-purposeful items, but a lot of science to support task-based practice. And task-based practice is the term that's coming to light and becoming more popularized of repetitive task-based practice. You're repetitively picking up that coffee cup and bring it to your mouth, not a cone. You're repetitively reaching up into the shelves overhead to get those plates. You're working exactly on the task that that person is struggling with, rather than replacing those items with something that's non-purposeful. Here is all of the science that I am talking about. I'm not going to go and waste your time reading you all of these things, but some of the things that are very important are that functional goals cause sustainable rehabilitation. That's huge. And those findings are highly significant. Neuroplasticity is accessible with repetitive task-based practice. So all of these things are really important in the brain. It's not just a matter of learning style for our patients. It's the fact that this type of rehabilitation is causing changes in the brain that are highly significant, and they're causing lasting results and more effective results. And then you see that little box on the right bottom side. Those are a bunch of other articles that I just wanted to include additionally, because there is so much evidence out there. Here's more evidence. That first slide is really all stroke based, because a lot of times that's kind of what we're focusing on. We're looking at neuroregeneration, but this has also been tested with traumatic brain injury, Parkinson's, hip replacement, spinal cord injuries, gait retraining. These are all things that we're seeing in skilled nursing, and we're finding these significant results with that repetitive task-based practice. I highly recommend you don't just sit here and listen to me lecture at you, but you go do your own research and you go look at your own resources, and make decisions for yourself, as I would with anything. One other thing I want to talk about is getting back to the basics. Long time ago in OT school, remember task analysis? That was like the foundation of OT. I remember that was one of the first classes that I took. And at first you think it's all kind of intuitive, especially knowing what we're getting into as OTs. And as you start to realize that task analysis breaks down every single little thing almost to a ridiculous point, you actually understand that this is essential to understanding what is my client really struggling with, what piece of the puzzle is missing that I need to go in and help them with. And I think these foundational abilities are essential to our job. We just have to remember that we need to focus on them. As a quick review, we have bottom up and we have top down approaches. The bottom up approach is saying, oh, this person is having trouble zipping their jacket. And I'm noticing during my task analysis that it's the pinch grip that they're not getting. So maybe you go forth and you do a bunch of interventions with doing fine motor skills, pinching, you're doing the therapy, you're doing a 9-hole peg test. That essential idea. Versus a top-down approach would be, my client is really struggling with a toilet transfer. And I would just do the toilet transfer with them as top-down, because the top-down is the functional task. And I wanted to provide that example of a toilet transfer. As you do your task analysis, you would be looking at posture. You'd be doing sit-to-stands. How's their dynamic standing balance, their upper and lower strength, their proprioception, so they know where are they in space when they're going to sit and stand. How is their use of any of kind of walker or grab bar or cane? How's their sequencing, their initiation, their cognition? Intervention ideas would be doing sit-to-stands at the parallel bars, dynamic standing activities, or static standing on a foam board to challenge that proprioceptive idea. How's their postural awareness and their safety awareness, doing those trainings? And even just education can be very powerful. I want to make a note, I didn't include TheraX in any of that because it is an option for strengthening, to fatigue, but the task itself should be attempted and integrated into that activity, whether it needs to be graded up or down. If someone is struggling with a toilet transfer, they should be doing that toilet transfer. If you need to spend your whole session doing a toilet transfer, just client education and doing those sit-to-stands and hand movement and proprioception, that can be your entire session because that's what they're struggling with. And I think that's really powerful to remind ourselves that you do what you need to do by focusing on that task specifically. We don't have to feel like we need to cover 10 things in a session. We can focus on one thing at a time. I think this is one of my final notes, is just remembering client-centered care. A lot of times we get caught up in this idea that we know best and we're noticing these deficits and we're explaining to our patient, I'm seeing these deficits, so let's work on it. But a lot of times we have to take a step back and ask, what are your goals? What do you want to do? Maybe that person doesn't want to learn how to toilet transfer and they're like, my home health aid's going to do that for me every time. Okay, great. But they're like, you know what? My daughter got me this little machine that has my crossword puzzles on it. I don't know how to use it, but I really want to. We can totally do that, which is one of the coolest things about OT. They can tell us anything in the world and we can say, all right, let's try it. So just a nice little reminder of, don't forget, client-centered care comes first. My big takeaways, just to summarize, client-centered care, super important. Stay skeptical, even as I talk to you. If you think I'm crazy and don't want to hear anything that I say, that's perfectly fine. Do your own research. Go forth and find your own evidence and find those things that are truly important. I think it's fantastic that we have resources like AOTA where we don't have to be skeptical of them. They are our mother organization and they're giving us good research that we don't have to be skeptical about. I think that's such a gift. And being open to that continuing education, being curious, constantly finding those continuing education courses that inspire us and awe us and are conversation starters between colleagues. I think that's really awesome to find something and share it with another colleague and say, look at this awesome thing that I found. What do you think about this? I really encourage you to de-implement inappropriate interventions, reflect upon your own treatment sessions and think, is there anything that I could be doing differently, trying differently, or altering to make more occupation-based or functional? And just reignite your passion for therapy. You got into this for a reason. Reflect on that reason. Go back and think, what was my goal when I first set foot into this profession? And just sort of fall in love with it again. I know this is a really difficult time in the healthcare world, in the skilled nursing world, in the rehab world, but you are all impressive, creative, caring clinicians. I know because I've seen a lot of you practicing, but also I've just heard incredible stories and how resilient you have all been through this time. So I thank you so much for your time. And if you have any questions, please contact me. I'll be with Marla a couple more weeks, but then I'll be off on my way to graduation. But again, I really appreciate your time. Here's some references. I hope you guys have a fantastic day.